Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can also find our previous episodes on Apple Podcast, Spotify, and on your favorite podcast app. Today, we have a special guest, Dr. Adam J. Brown, the host of the wonderful podcast, Rheuminations. Dr. Brown is here as the unofficial rheumatology historian to share stories about the origin of rheumatology, its pioneers, and their notable contributions. We'll also explore the current state of the field and where it might be headed in the future. Dr. Brown also discusses how he uses the history of rheumatology to improve patient care and enhance education with his medical trainees. Dr. Brown is staff and associate program director at the Cleveland Clinic. He did his internal medicine residency at Georgetown University Hospital and then rheumatology and vasculitis training at the Cleveland Clinic. He's the host of the podcast Rheuminations and editor for the online quiz platform Rheum and Boards. Ready to start at the beginning? Enjoy. Adam J. Brown, welcome to the show.
Hey, thanks so much for having me. I'm very happy to be here.
You know, Adam, I see you as the ultimate rheumatology historian. So we thought we'd bring you here and talk a little bit about, some stories about what made rheumatology what it is. And I wanted to start with that word rheumatology. Where the heck does it come from?
It's kind of a vague story on the term rheumatology. And usually when I tell it, people kind of give me a blank stare, like, that's not very helpful. It doesn't really explain, it doesn't really explain much. And the answer is it's just a word that it means to flow. And, back to the days of the humors and how people thought things were in imbalance. People thought rheumatology, like joint issues, were just imbalances kind of flowing to different joints. So rheum means to flow. That's it. And it's not the most satisfactory answer. And we kind of kept on chucking with the word. I mean, kept using it and it persisted. So it's been a very persistent word that people still kind of cock their head at a little bit. Like, what does that mean? If you tell people you're a rheumatologist, still they're like, I don't know what that does. And like, well, joints and things. And we're mostly autoimmune doctors now, but it doesn't really describe things very well. And we still have other words that are involved with the flow of disease and flow of humors, like gout, for example, that comes from gota, to drop. So gota is like to drop, and like the disease or the humors kind of dropped into your toe, for example. It's also why we use the abbreviation GT for drops, like eye drops is from gota. Yeah, so gout and rheumatology in general are kind of back in the days of things flowing in the wrong way, basically. But again, not the most satisfying answer, but rheumatology, it's still a pretty vague specialty.
Should we advocate to change the name?
Yeah, maybe you should.
Inflammatology?
Inflammatologist. I actually like that. Inflammatologist or autoimmunologist.
Yeah, that's better because, like a dermatologist, what they do? They deal with the dermis, right? Cardiologist, the heart.
Gastroenterologist, very self-explanatory.
Yeah. Maybe we should advocate for that, Adam.
I think so.
Yeah. So that word has, very little to do with rheumatology, but I guess it's stuck. But when did rheumatology actually become like a separate field, or like when did people start understanding that rheumatic diseases are different from other stuff?
Yeah, it's sort of a hard question to answer because even when we were treating them, we still didn't know about autoimmunity that well. So it's hard to pinpoint exactly when like autoimmune driven field became an autoimmune driven field. But I can tell you that from the ABIM, American Board of Internal Medicine, actually recognized rheumatology in the 70s. So I think it's the early 70s. So actually became like a separate board certification was in the 1970s. But even the history prior to that wasn't that long. We recognized gout, we recognized inflammatory diseases of the joints for a long time. Like rheumatoid arthritis was probably kind of first described in probably 1800, that we think was a clear description of someone suffering from rheumatoid arthritis. So the disease were recognized for a long time, but it wasn't really even till the early 20th century when we started actually kind of compartmentalizing it as its own disease process. Again, still decades away from knowing this was an autoimmune condition. So I think that it's a little vague, but I think I can tell you that it's actually a Dutch physician, Dr. Jan van Bremen, who actually was the first to develop the International Committee on Rheumatism. So that was the first big separation that this is this kind of field is its own thing. And then America finally caught up pretty quickly. I think a Mayo physician was in Europe, and he saw that this International Committee of Rheumatism existed, and he came back and then joined with a physician in Philadelphia, and they kind of established it's a very long, I'll probably screw up, like the American Committee for this control of rheumatism or rheumatology, rheum something. I know it was ACCR back in the day, which eventually again had many names, which eventually became the ACR.
And I guess at that point, like they were grouping diseases based on inflammatory diseases of the joints. Is that sort of what grouped them together?
I think one of the papers they first published, like, what is rheumatism? Question mark. But I think we still have a hard time, as we just discussed, defining that, right? And I think it was mostly trying to like compartmentalize this disease better. I mean, we didn't get psoriatic arthritis till the 1970s, right? So,
Wow.
we're still decades away from compartmentalizing the diseases that we, think of today. And there's some papers on psoriatic arthritis in the 50s, but it was like mostly like big time, like this is its own entity in the 1970s. So it was mostly probably describing gout versus rheumatoid arthritis versus like septic joint, kind of some basics on that standpoint. But a big leap happened after World War II with the discovery of rheumatoid factor. So rheumatoid factor was like the first like autoimmune disease that, hey, maybe there's some sort of immunologic phenomenon happening with this. The interesting thing about that is it was actually discovered before World War II, but it completely like fell. It was published, but no one paid attention to it because obviously World War II happened. So it was like
something was happening over
something
there.
happened in the world. I'm not sure what was happening in the 40s, but so it was actually rediscovered in the late 40s after World War II, and that's when it said, "Oh wait, something's happening here. There's some phenomenon with these people with these joints," and the ideas started being pushed about autoimmunity, and then ANA was found, so it started like pushing more towards maybe this is autoimmunity. I mean, autoimmunity was brought up well before that. Horror artotoxicus is the word that was thrown around. It was not like a brand new idea, but it hadn't really established itself as a phenomenon. So I think rheumatology at that point was kind of recognizing joint swelling, but there's this big push at that time that is probably infectious. So everyone kind of thought, oh, this is probably some infectious process happening. Infections were, again, just discovered a few decades before. So that was the hot topic. Everything was probably caused by infection. I get it. That was a completely game-changing discovery in medicine. So they probably said, well, infection's probably doing everything, right? So that was the same thing with rheumatoid arthritis. Had these totally healthy people, then all of a sudden, boom, they had, big swollen joints. They probably thought they got exposed to something, and they got some sort of infection. We have some of our old drugs because of that. We have sulfasalazine because of that. We have sulfasalazine, which is, again, sulfonamides were the first antibiotic ever discovered. The long story short, sulfasalazine came out because they were trying to figure out how to get antibiotics to the joints better. So that's why they were using sulfa, and they put the amine group on and thinking that had better chance of getting into the joints, and that's how we got sulfasalazine. So one of those totally accidental things that kind of is the story of rheumatology. It's like a lot of things that we were treating something else and it still worked, and it worked. so that's sort of interesting. Yeah. So but it wasn't until Philip Hinch and Edward Kindle at Mayo used cortisone that actually as a true anti-inflammatory use of a drug that actually helped treat what was then defined as rheumatoid arthritis. And that was, again, rheumatoid factor discovered around that time. So it started becoming a better defined
that was in the 50s or
40s. Yeah, in the 40s. Yeah. So I actually can't remember the exact year on that, but it was in the 40s, I believe. I think it was right before the discovery of rheumatoid factor, if I'm correct.
Mm-hmm.
So Philip Hinch was obviously a big player from a rheumatology standpoint across the country, because not only he's most famous for utilizing cortisone against rheumatoid arthritis, but there's a survey in the 60s to all American rheumatologists trying to figure out where everyone kind of trained, and 10% of all rheumatologists across the country had trained under Philip Hinch.
Wow,
so he
big
had
influence.
So he had a huge impact and huge influence on rheumatology in America. I think this is going to be a hot take, but I think that people talk about like the brilliance and like, oh, using cortisol to actually treat rheumatoid arthritis was such a brilliant move, but it's totally accidental. So I think his bigger impact was just on the training of rheumatologists and establishing rheumatology as a major specialty. But looking back at the story, this is going to upset people, I'm sure. But looking back at the story of rheumatoid arthritis and how Dr. Philip Hinch was, how he was investigating, it was totally like off. Like he was discovering, like he was looking at jaundice treating rheumatoid arthritis. He recognized people with who had jaundice who had better control of the rheumatoid arthritis. That was not that doesn't really play out anymore. Like I'm not sure what that was about. And then but he did correctly, I think, recognize that some people who were pregnant had improvement in their rheumatoid arthritis. But he was, he had famously said there's some substance in these patients, they called it, and that is controlling the disease when they have jaundice or when they're pregnant. And there was a lady with rheumatoid arthritis that was very severe, and she was like, I want treatment. I'm not going to leave this hospital until I get it. And he was like desperate, and he recognized Edward Kendall was the really brilliant chemist and really scientist who was like figuring out cortisone. And then he kind of just like was throwing everything against the wall, and one of them stuck. Cortisone really stuck, and it totally changed rheumatology. But again, he wasn't thinking it was autoimmune. He thought there was some metabolism problem and rheumatoid arthritis. So I think that again, obviously I'm glad it happened. It was a big deal, but I think it was a bit of luck. And Edward Kendall was actually targeting something and trying to figure out something. Philip Hinch just threw something against the wall and it worked. But again, he had a huge impact otherwise. Like he completely
with the training.
Exactly. He totally established rheumatology in the United States. I'll probably get some hate mail for this, but
Got it. No, it's so interesting. So that was like 1940s, 1950s, and it took, until you said the 1970s for the ABIM to actually certify the rheumatology as its own specialty. So before then, it was sort of this unofficial group of physicians that were, many of them who trained under that same guy and sort of were treating the similar group of diseases.
Right. I think someone documented in the 1930s, there were 6 clinics across the country of rheumatologists. So it was a very small group. So I guess it's not totally surprising that one person had such a major impact on so many different physicians. But it's sort of like once cortisone came out in the 50s, Dr. Marion Ropes, so I have a podcast episode on her, kind of started better describing synovial fluid and having an understanding was, taking arthrocentesis. And then Dr. Joseph Hollander came around and started giving injections of steroids. So we started becoming much more comfortable with the anatomy and physiology of synovial fluid, which I think kind of helped our understanding of these diseases. But it wasn't until the 1950s that we started kind of saying, okay, this is an autoimmune phenomenon, and that's probably a combination of cortisone helping, and also all these autoantibodies that started being discovered, the rheumatoid factor and anti-nuclear antibody, for example. So after that, it kind of just like rocketed up. And as I mentioned, in the 1970s, we started actually having its own specialty. But we kind of lagged behind in treatment. We had aspirin, we had these strange things. We were using gold, and we started using gold because, that was used in tuberculosis. And someone thought that people with tuberculosis also had joint pain, so maybe it works with rheumatoid arthritis. And it did. It was, again, a complete accident. It caused a lot of side effects. So obviously, we don't use it anymore. And it'll probably only had a moderate benefit. It's also a pain in the butt. It's coming like once a week to get their golden shot. So it was a big deal.
Yeah, I remember. So one of my previous nurses was like the gold nurse.
Oh,
She's
yeah.
the one that was trained to give gold to patients. She is incredible stories.
Absolutely. I mean, it gives you an appreciation of what people went through,
Yep.
of like these diseases are horrible, and they really completely debilitated people. And they're getting these gold shots that may or may not help them. It may cause all these rashes. It may cause all these other problems, but they're desperate. They really, really wanted help. And now we have all these drugs that just like, boom, they just work, and they just completely change people's lives. So it's a very exciting time to be in it. But I think keeping perspective of where it came from is really critical to give us an appreciation, right, of what people went through. Like telling the story of gout, right? So gout, we have allopurinol, and that was discovered accidentally. All these things are just accidents, and they've really, really, really changed people's lives. So it's been quite a change. And one of the things I think was funny is one of my colleagues talked about, after rheumatology was like its own specialty, we didn't have a whole lot to do because we didn't have any major new drugs in the 70s and 80s. So like people just kind of sat around arguing about names of things and how to categorize things. That's why we have mixed connective tissue diseases, because everyone's just standing around arguing about different diseases. So that's how we got some of our diseases, just because of people didn't have anything else to do. up until the 90s, we actually get pretty much the dawning into the era of modern rheumatology with biologics. That's when everything really, really shifted. But for a few decades, it was kind of just like people arguing about diseases for a while.
How did methotrexate came to be used in rheumatology?
So it's used in the 40s with cancer, and they recognized that one of the side effects of methotrexate was lowering people's immune system. So once we started dabbling with the idea that these diseases could be autoimmune, methotrexate kind of came to the forefront early. Like, hey, we have this drug already for the use for cancer. We know that lowers people's immune system, and there's actually a little bit of studies in the 40s using it in rheumatoid arthritis, and it seemed to work. The issue was we didn't know how to dose it. And I think people were really, really terrified of it because, they saw that people with cancer getting methotrexate got really sick. They got cytopenic, vomiting, hair falling out, and, getting all these sort of secondary infections. So people were kind of associated that highly with that drug. So no one was in a big race to utilize it in people with rheumatoid arthritis. I don't think we had the idea of what this drug does well enough. And we also probably didn't know that you could drastically lower the dose and it would still work. It would still work to some degree, even though it doesn't cause cytopenia. So that took a while to figure out. Inflammatory bowel disease was ahead of the game on that. They were using it in the 50s for, I think, ulcerative colitis or Crohn's. I'm not sure which one. And it seemed to work. So they kind of took up earlier than rheumatology did, or rheumatology dabbled with it in the 40s, but it wasn't until the 80s and 90s where people said, oh, wait, we actually use this to a much safer degree. There's like decades of us knowing it probably helped, but not utilizing it, and probably underutilizing steroids too. I mean, everyone had this in the 70s, 80s, noticed this idea that steroids were just going to kill everybody. It was this really, really, really toxic. So a lot of patients suffered for a long time when we had drugs that actually helped. So which must be very frustrating to hear. But it took a long time to figure out the dosing of methotrexate, which I think was probably the biggest hurdle in using it in rheumatoid arthritis.
Yeah, and then the last drug I always wonder is about the use of NSAIDs. We sort of take NSAIDs for granted these days because you could pick it up over the counter. Everybody has, from infants and children to like older adults, everybody has taken NSAIDs at some point. But I'm sure that there was a time before NSAIDs and then there's now.
Yeah, so that's a great question. And again, back to where rheumatology was in the 70s and 80s when everyone was kind of like debating disease names. That's what people call rheumatologists NSAIDologists. They had to talk about how like we argue about different TNF inhibitors now. That's what they argued about different NSAIDs. Like is this more COX-1 or is this more COX-2? They're trying to figure out which one the best approach for each individual patient would be. Yeah, but to your point, these just ubiquitous drugs. They're like the top 5 most commonly given drug. As you said, almost everybody across the world has probably taken one to some degree. So that starts with aspirin, obviously. Aspirin's kind of the long story. So I make a joke that humans have been out to get prostaglandins for centuries without even knowing it. We know what prostaglandins were, but now we know that it blocks prostaglandins. So we use aspirin for centuries, basically. And in the late 1800s, it started being synthesized by Bayer, and they're able to give it kind of more consistently instead of like in a powder. People just kind of took a powder beforehand, and they recognized it helped with fevers, it helped with joints. And people used it for a whole lot of different things. It wasn't until a doctor came out in the mid-century that said, wait, maybe aspirin has some anti-inflammatory properties to it. Maybe it'd be useful for rheumatoid arthritis. He's working for a pharmaceutical company and he got assigned rheumatoid arthritis. Like, you got to fix rheumatoid arthritis. People are taking high doses of aspirin, gold, and it doesn't seem to be working that well. So try and figure out a different drug. So he wanted to, and again, steroids were used at the time, but everyone at that point recognized the toxicities of steroids. So he wanted to design something new, and he wanted to try and draw, for the very first time, something that is not a steroid, but also an anti-inflammatory, hence non-steroidal anti-inflammatories. So he looked at the structure of aspirin, and he's like, well, what part of this is causing the anti-inflammatory? What part of the structure is causing the antipyretic? And they pretty much just used chemistry and a lot of guinea pigs. And the guinea pigs, or poor guinea pigs, were involved with these studies. A couple different models of inflammation when the guinea pigs were utilized. And they just gave it a whole lot of different changes of the structure of aspirin. And they tried to figure out what was tolerated, what people tolerated pretty well, and then what worked. And they finally came up with ibuprofen. And ibuprofen, actually, out of all the hundreds of synthetic chemicals he made, it was not the most potent anti-inflammatory by any means that he had made, but it was the best tolerated, the best tolerated drug. That was one of the biggest criticisms of all these. The aspirin prior to that was it upset stomach. And that's when it was primarily salicylic acid. And then someone figured out how to put a acetyl group on it. So you get acetylsalicylic acid that actually helped it with the people tolerating in the stomach. So ibuprofen came out, and then it was just a blockbuster drug. And the first trial of it in rheumatoid arthritis was like 9 people. So it was like very different trial structure, and everyone got the drug. So it was like prednisone versus aspirin versus ibuprofen, and they got 1 week of one drug, and they switched to the next week of the next drug. And they check like how did you feel, grip strength, things like that.
Oh,
And
interesting.
and ibuprofen seemed to work. It didn't work as well as prednisone. As prednisone was 15 milligrams, but it did help. So they actually approved it from that. So that was it. The nine patients is a different world, right? And
Incredible.
then so there's just a ton of copycats at that point. Like it was just flooding the market with different drugs. But again, I think one of the fascinating stories about the NSAIDs is that all these drugs were developed without having a clue of how they worked. They didn't know about cyclooxygenase. They didn't know about prostaglandins at the time. So it was like a total mystery. They just recognized one drug works. We know the structure of it. Let's try and mess with the structure and see if we can make another one. That's what happened. Late 1970s, we discovered COX-1, but we didn't know it was COX-1. We just knew it was COX because it's cyclooxygenase, because we didn't know there's more than one. So everyone started, and then that led to Dr. John Vane, who won the Nobel Prize for figuring out that both ibuprofen and naproxen at the time and aspirin inhibited the formation of prostaglandins. That was like a big moment in the 70s. Like, oh my God, all this drug we've been using forever and that really helped actually have been involved in prostaglandins. And that opened the door for all the prostaglandin research, what they're doing. And the next big jump happened in the early 1990s when they discovered cyclooxygenase 2. So COX-2 was discovered, and they were able to figure out how to try and target just COX-2 because they thought COX-2 would be safer, because they thought cyclooxygenase was needed for, the stomach. So we recognized gastritis and kidney injury was a problem with inhibiting cyclooxygenase 1. So everyone jumped on bandwagon on cyclooxygenase 2, and you may know the story, but that ended up with Vioxx, the drug Vioxx, and I can't remember the generic name that starts with an R. And that was taken off the market after they recognized that it caused a lot of myocardial infarctions. So since then, it's been kind of this balance of cyclooxygenase 1 and cyclooxygenase 2. We're using them for literally centuries before having any idea how the drugs worked, which is pretty interesting. And we're taking them like crazy. As you know, it's like the third most common drug prescribed and taken in the world.
Yeah. You tell those stories about how these drugs came to be and how it seems how different things are these days, where we are looking at the pathophysiology of disease and then saying, well, what if I inhibit one of these inflammatory molecules? How can I, make an anti-TNF blocker or IL-6 blocker and see what the benefits of that is?
We think we have so much more pre-planning now of like what exactly we're going after. But I guess you kind of have to when the drugs now are so targeted, right? They're so targeted against a very specific cytokine, for example. So you have to really want to know that cytokine is doing something before you develop the drug. Can I talk about TNF a little bit here? This.
I love it. Yeah, that was my next
Oh,
question.
great. So
How did we get that?
that's a great story of science and medicine, and that completely changed the disease again inadvertently. This is the story of rheumatology. Is kind of like, oh, we developed this drug and it doesn't work for other things, and then someone's like, what about in rheumatoid? And they raise their hand, and it totally changes the field, right? So tumor necrosis factor was a cytokine that was described independently twice in the 1970s. The first time it was described was in a mouse lab looking at tumors, and they found the cytokine that actually necrosed the tumor. So that was a big deal. It was also discovered independently in looking at animals in certain parts of Africa that had parasitic infections. They recognized these people had these high cytokine levels and while the animals were kind of wasting away. So they called it cachexin. So the cachexin was the other name for it. They was later found, it's the same drug, and you already called it TNF, so you can keep it as TNF. So the name tumor necrosis factor, people got really excited about it. Hey, maybe this necrosis tumors, right? So we should probably use it in cancer. Looking at these early studies, pretty wild. Like all these cancers got lumped together, like bone marrow cancer plus solid tumors all in one trial, which would never happen now, obviously. So what they did was they actually synthesized the tumor necrosis factor and then it's pretty much just injected it or infused it into people, thinking that it's kind of melt away the various tumors that were used in these trials. So what happened was that they actually, using some translational science, actually recognized what level of TNF in the blood it would have to be to actually cause like tumor necrosis, and they could not get it in the people. What happened was the people who were getting the infusions became extremely tachycardic, then became hypotensive, diaphoretic. They felt like crap. They felt really, really badly. And they said, oh, the people, they can't tolerate, they're trying to give them fluids to reverse it, and nothing really helped. So someone said, you know what this looks like when these people get a lot of tumor necrosis factor? It kind of looks like septic shock, right? These people are getting these, probably getting tachycardic, they're getting hypotensive, right? That's what happens when these patients get, this bacteremic and they get septic shock. What if we, instead of give TNF, what if we blocked TNF? So that was actually the development of the monoclonal antibodies against tumor necrosis factor. And that was I think one of the biggest pushes. This was going to be extremely expensive to develop in the first monoclonal antibodies. And I think the excitement from the pharmaceutical company at the time was like, well, septic shock's pretty common, right? So I think a lot of people are going to probably use this drug if we develop it. So they developed anti-tumor necrosis factor, and they started utilizing it in the early 90s in multiple clinical trials of septic shock. And in the animal trials, it worked great, by the way. And then in the humans, it did not work so great. So it just didn't do anything. It didn't make anybody worse, which was great, obviously, but it didn't seem to help anybody. And the drugs were very, very expensive. So it was a huge disappointment from a septic shock standpoint. I said, "Oh, this is not helping. This is what a disappointment is." We put, I don't know how many millions of dollars to develop these monoclonal antibodies in the 90s, and it didn't work. So long story short, they had all this drug, and at that time, there's some researchers at a couple different institutes looking at cytokines in rheumatoid arthritis, and they had looked in particular. They saw this, assortment of cytokines being elevated in rheumatoid arthritis, like IL-1, IL-6, tumor necrosis factor, yada, yada, list goes on, right? So there was this kind of question of, hey, there's this new anti-TNF they're using in septic shock, would it potentially work? And there's a lot of naysayers. They're like, no, it's not going to work. There's like 80 cytokines that are elevated in the synovium of patients with rheumatoid arthritis. So how's that going to do it? If you block one of them, what's it going to do? There's some animal models they were working with in rheumatoid arthritis, and actually were able to measure the various cytokines with inhibiting TNF, and actually showed that IL-1 dropped significantly and IL-6 dropped significantly in these mouse models. So that opened the door, like, oh, wait, maybe this will work. So that's when they utilized infliximab in a patient with rheumatoid arthritis. They admitted her to the hospital. The researchers slept in the same room as her. they're so worried what was going to happen as they got it. Because, septic shock, these patients may die. The rheumatoid, it's not going to kill them right away, right? So they had this big ethical issue. Is it worth taking this drug if what you're treating is going to kill you? The big leap they had to make, and they did it, and the patient tolerated it well, and it was just a dramatic change. The interesting thing about that study was they had a handful of patients that they first described utilizing this drug, and these patients were never getting a trial nowadays. All these patients were seriously had erosions everywhere, severe deformities, could barely move. They tried everything. So all of these patients responded great. So it was a dramatic change. It completely changed our understanding of rheumatology, basically, and actually targeting cytokines. But it all came from a tumor in a mouse, and utilizing it in cancer, that didn't work. Utilizing it in septic shock patients, that didn't work. Then rheumatology takes the scraps and totally changes the specialty, right? So that's the fun story of TNF. Is again sort of accidental, but we did it totally changed our profession.
And I feel like it's one of those things, once the TNF inhibitor works, then that allows us to better understand the disease and to better understand, what is TNF actually doing and how is it influencing all the other cytokines. So I guess it also helped us to better understand what happens in RA.
Everyone thought all these cytokines were not talking to each other. There's all up and all causing problems, but it started pointing to oh, there's maybe this kind of they're all interconnected somehow, like big spider web, and maybe interfering one can actually have much more impact than you think. That totally opened the door for all these monoclonal antibodies. And again, from a pharmaceutical standpoint, they weren't thinking about rheumatoid. Oh, it's such a rare disease. Why do I want to develop this drug for such a rare disease? And oh, wait a minute, these patients are this is a lifelong illness. So pharmaceutical companies were initially kind of hesitant to jump into the rheumatology field because our diseases are so rare. But obviously they did pretty well with these drugs because unfortunately, they're lifelong diseases for the most part.
For now,
Yeah,
that's
for
right.
now.
We talked about CAR T therapy a few episodes ago, and maybe hopefully that'll change things, but we're certainly not there yet. So, Adam, you said in the 90s the TNF inhibitors, and that's certainly brought in TNF and all the other biologics that were targeted for rheumatoid arthritis. So, with your perspective of sort of the last 200 years of rheumatology, where do you see that we are now? What do you feel like the big challenges are, And can you predict where we're going to be headed in the future?
I think it's again, a good reminder where we came from, like how bad these diseases were and how much we can do for the majority of patients now is fantastic, right? I think we've come a huge way, and we got to be appreciative of where we are now with the various arsenal of medications that are very targeted and for the most part pretty well tolerated. So that's just very exciting. I think the big questions that linger in rheumatology goes back to the 1940 treatise from the American Committee for the Control of Rheumatism, the ACCR, in the 1920s. Is what is this? What are these diseases, right? And I don't think we have a good answer for it still. We know they're autoimmune for the most part. We think we know what that means. Infections may still play a bigger role than we ever imagined. We learned that from multiple sclerosis, right? We have these old viruses that probably trigger it. So I think that's we still have so much to learn about why these diseases happen, And I think that's kind of fascinating to me how we still haven't figured that out, right? Like,
Yeah.
why do we not know how this disease happened? As a patient, every day I get asked that question. Well, why did I get it? I'm like, I don't know. That's a very disappointing answer.
When people ask me why I became interested in rheumatology, I tell them exactly that. Like, we have no idea what's going on. And, the possibility of working in that field and sort of either seeing our understanding increase or contributing to that understanding, I think is like really interesting and fascinating.
I can't think of a field more rapidly evolving. You can argue oncology is because they have, a lot more people doing it, a lot more money. But I think that it's kind of amazing we don't know where that is, where that is with all the technology and in biology that we understand. Another fundamental thing that I get asked about all the time when I'm working with residents is we recognize all these patterns in rheumatology, but why does rheumatoid arthritis like the MCPs and so on? I'm like, I don't know. Isn't that a while that we don't know that? Or ANCA like the lungs and kidneys where it doesn't bother the liver. It's like what a weird. There's something clearly different anatomically about these diseases that we still can't answer that fairly. What we think of as a basic question: why does inflammatory myopathy like the proximal muscles and not the distal muscles? So there's so many fundamental questions that we don't know. What I'm excited about, to sort of answer your question better, is I think what Vexus gave us and recognizing somatic mutations, as a potentially interfering with the immune system. Before that, we didn't really have a clue of why diseases could happen later in life. And I think that, we have these patients with VEX is, sort of rare. Now, I think it's more common than we think as we're learning now. So we think of germline mutations being mutations that you're born with, and maybe people have, a familial Mediterranean fever gene that they're born with, right? But the oncology world has known about this forever, where you can get mutations, as you get older, and that mutation can cause cancer. Right. So it's a somatic mutation that can happen later in life. So I don't think rheumatologists really been thinking about that until Vexus came around. And once Vexus got here, we said, oh, these patients have a somatic mutation later in life that can trigger this inflammatory disease known as Vexus. So is that going to open the door for a whole lot more of disease discovery? Why do these diseases have to be age specific? That doesn't make any sense, right? Like polymyalgia rheumatica or giant cell arteritis. Why do they only happen almost exclusively in patients above the age of 50? So I think that starting to better understand potentially somatic mutations and their impact in rheumatology, I think I'm very, very excited about that, seeing where that goes and the door that Vexus opened for that. And then also your question of, where we're going to be from a therapeutic standpoint is, I think the CAR T story sounds almost too good to be true. This is really going to be that great. I think it's going to be hopefully being able to kind of bottle down CAR T to be a much more simple process to undergo, and potentially curative, which is just unheard of for these diseases. Again, we're all happy with what we can do now. We can mostly treat these patients and mostly have a somewhat normal life, hopefully, in the majority of patients, but they still have to take the drug. So, the question of whether or not CAR T can actually stop the process, even again, it's kind of wild, even without us knowing what started it, right? What started the process, which is wild, but it's exciting. This field's moving very quickly, and it's a fun field to be in, learning so much. It's a field for everyday learning. There's just so much stuff to learn, and it's exciting to try and keep up with it. So I love it. I think history gives me a better and a better appreciation of where we are today.
Great. And how does the knowledge of history help you as a teacher? How do you incorporate, these stories that are so incredible and interesting in your teaching with residents, with medical students, with fellows?
Yeah, I think that one of the things about rheumatology, if you're just jumping onto it, you're rotating through it, you just see we use so many different medications. How do you pick that one versus that one? It's kind of overwhelming to see why are these patients on X, Y, or Z. And if I kind of step back, say, hey, this is where we came from. This is why we're inhibiting this antibody. It kind of gives people a story. I think that like a story is so critical and learn, at least for myself, like having a story attached to a fact makes it so much more digestible and better to memorize. And like learning that, allopurinol is used for cancer. It's trying to increase a drug called 6-mercaptopurine. It's trying to increase the levels of 6-mercaptopurine in patients being treated for cancer, because they recognize that 6-mercaptopurine in humans was being broken down by an enzyme called xanthine oxidase. And they're like, oh, we can't keep the levels high enough to treat the cancer with the 6-mercaptopurine. How do we block its destruction? Like, well, let's block xanthine oxidase. So they used it, and it kept 6-mercaptopurine levels up. But it didn't help the cancer very much. But it did. Luckily, someone knows, hey, we're checking a lot of labs in these patients on the drug, and it seems to lower the uric acid. So I think that little story behind it is really helpful. And again, it's also a good learning anecdote, because if you know that 6-mercaptopurine and azathioprine are very similar drugs, that you can't give allopurinol with azathioprine or 6-mercaptopurine. The fundamental reason why that is because literally allopurinol was made to increase the level of that drug, so that could lead to drug toxicity very, very quickly. So I think it's like, A, it's an interesting story, you learn it better, but B, now I know why you don't want to use other drugs with it, because that literally it was designed to increase those levels. So I think that telling stories helps learners, it helps appreciate where we came from, and it helps the little anecdote along with the fact just kind of sticks better.
And do you ever use these stories with patients? Like, do you ever tell them about, like, when you prescribe a methotrexate, it's like, hey, did you know?
Yeah, it's a little background on methotrexate. Like, if you Google this drug, you're going to think I'm trying to kill you. Right? So you're going to think all the huge side effects. And I kind of walk them through very, very briefly about how it's used for cancer, but I recognize that we've used much, much, much lower doses in patients. Another one I use a story for is Plaquenil, right, or hydroxychloroquine, just because people were like, I looked it up, it's an anti-malarial drug. Why on earth am I using that? Like, well, interesting story. In the 1940s, I tell a little fact about, we've been using it as anti-malaria forever. The quick fact of it is that we had in the US, we had all these soldiers off in the Pacific, and a lot of these soldiers were getting malaria. And at the time, we were using the hydroxychloroquine to treat malaria. So all these soldiers were getting the hydroxychloroquine prophylaxis to prevent malaria. And they recognized that a lot of the soldiers with lupus and rheumatoid arthritis started feeling better. And when they came back to the States, they kept asking their doctors to keep giving them hydroxychloroquine. They're like, why am I giving anti-malaria? They're like, oh, it helps my joints. And that opened the door for that drug. Like, why? So that little tidbit made patients go, oh, that's why I'm getting anti-malaria. It was a total accident. I don't know if it helps the cause, but it's at least that's where it came from. Like, we don't look around like this antiparasitic will probably help rheumatoid. No, it had some story behind it, like of how we started utilizing. So I think patients appreciate that, and why they're getting the drug.
Adam, it's been a really fascinating discussions with you. I really enjoy your podcast, and I encourage everybody to listen to Rheumination if you haven't already done so. But keep telling stories and keep up the great job, Adam. I love listening to your show.
Thanks so much for inviting me. It was great talking to you. I really enjoyed it.
And the rest, as they say, is history. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our shows and notes for this and other episodes at acronair.org, Apple Podcast, Spotify, and on your favorite podcast app. Until next time, keep learning and making history. And of course, be healthy.